So one of the things I've tried to emphasize along with my colleagues in 𝐓𝐼𝐷, the manual therapy community, is that both manipulation and repeated end-range movements are end-range forces. So in that respect, they're not different. The big difference, though, being that, in MDT, end range may be achieved by the patient and thus provide a means for the patient become empowered to self-treat and manage their condition independent of the clinician. So, and I think that's where Rob Mckenzie met his opposition in the physical therapy community, was that, many of the outcomes he was achieving could be gained through the patient being in control as opposed to being manipulated. And Mckenzie was a manipulative physiotherapist and was one of the founders of the New Zealand Manipulative Therapy Association, and did utilize those procedures as part of his practice, and still incorporated manual procedures in the management of patients according to MDT, but following the exhaustion of patient-generated forces. So I think when we consider end range as being a part of the motion or the range that can produce dramatic changes in the patient's mechanics, especially if it's their preferred direction or their directional preference, and when we see those changes in baselines, we can explain it via various theoretical models. Mckenzie's original theoretical model being that of the disc, but there's emerging evidence in the literature of these end-range procedures manipulation producing a neurophysiological effect that reduces pain and guarding and gets the patient moving again and functioning again. So, in that respect, we've had some success in presenting at the 𝐓𝐼𝐷 conference and in explaining that, MDT does fall within the realm of orthopedic manual physical therapy, with one of the big differences being the emphasis on patient-generated forces initially.